The most common, disease that can cause sudden death, very prevalent of angina, of ischemic heart disease. Okay, and describe the pathogenesis, the pathological changes and effect and complication of myocardial infarctions, and also explain the lab diagnosis of myocardial infarction. Okay, you have had a lecture on atherosclerosis.
Yes.
Done. Right. Thrombosis. Done. Okay. So all are connected to this topic because those are one of the most common causes for ischemic heart disease. Okay. So what is ischemic heart disease? The name ischemia means
Low of
lack of
oxygen. Lack of oxygen.
lack of oxygen. So you can imagine ischemic heart disease is when your heart do not get the required oxygen. Okay, and imbalance between myocardial supply, which is perfusions, and cardiac demand for oxygenated blood. So your heart can, under normal circumstances, your heart might demand certain amount, but under other circumstances, your heart might demand, the demand will be increased. For example, when you go exercise, when you jogging, run marathon, or whatnot. Okay, if you had a good heart, good blood supply, is not affected by any disease. I mean, the coronary artery that supply the heart. Okay, you will get, it will compensate. You will get the increased demand of the oxygenated blood that your heart wants. But under certain circumstances where your coronary artery, your blood, your supply, the vessels that supply the heart cannot function properly, is blocked, under spasms, got some kind of inflammations. Okay, they cannot supply the oxygen demand that your heart want. Okay, so there will be ischemia, right? So there are closely related syndromes caused by myocardial ischemia. So when we talk about ischemic heart disease, pathologically and a lot of it you see clinically. So in clinical you will see a few related syndromes. So majority causes of ischemic heart disease is coronary atherosclerosis. It's like more than 90% of the case of ischemic heart disease is actually due to coronary atherosclerosis. So you have to know your coronary atherosclerosis, the how atherosclerosis develop, okay, by heart, by heart. Okay, other causes include increase in demand, for example, increased heart rate or hypertension. Because you know hypertension, when you got hypertension doctor lecture, yeah, you can have what? How does it increase in demand in hypertension? Jadi apa?
Jadi
When you got hypertension, your heart will
one more.
pump against the high pressure lah. So what will happen to the heart?
Increase the
The
work.
hypertrophy. So when there's hypertrophy, there is increase in demand. Okay, there's increase in demand. Usually pakai like 70%. Now because of increase in demand, need more. Okay, diminished blood volume in the case of hypertension or shock. So you already know about hypovolemic shock. Kan, when there's hypovolemic shock, it's not enough blood volume to take up your oxygen to send to the heart, right? Diminish oxygenations because your lung cannot receive adequate oxygen. For example, in the case of pneumonia, in the case of congestive heart failure, because the heart will eliminators, the exchange of gases reduce, kan? Like in COVID cases, COVID pneumonia, okay, reduce oxygen exchange within the lungs, so reduce oxygenations of the blood can also lead to ischemic heart disease. Okay. Diminish oxygen carrying capacity in case of anemia, okay, tak cukup kereta nak bawa the oxygen to your heart, not enough the vehicles. So the vehicles ada penumpang lain lah, carbon monoxide poisoning, for example, or any other gases that take up the space to carry the oxygens. Okay, so any causes, but mostly more than 90% are coronary atherosclerosis. Risk factor, usually we will divide risk factor into non-modifiable and modifiable. So why is it non-modifiable?
Cannot be changed. Cannot be changed.
Tak boleh tukar lah, dah tua-tua. Makanlah anti-aging pun mesti tua. Male gender, externally can change, but somehow, but can change because male who takes hormone, okay, takes hormone, estrogens and whatnot, somehow they will have. Tapi dia family pula lah, tak sanggup dah pula kan. Okay, family history of premature coronary artery disease in first degree relative. Okay, so this usually associated with some kind of genetic. Okay, so that one is non-modifiable. Genetic thing cannot modify lah. Okay, not for now. Okay, and modifiable is the thing that you can modify. So under modifiable, you can control. So this is the thing that you can control when you see your patient. This is the thing that you want them to control. Okay, dyslipidemia, high LDL cholesterol, low HDL cholesterol. I'm sure you have learned about familial hypercholesterolemia. Okay, but still that thing is memang genetic, but it can be controlled by by medications, by changing lifestyles. Okay. Hypertension, of course, it can be controlled by medication. Same thing as diabetes, obesity, smoking, if a habit, lifestyle, lack of physical activity, unhealthy diet, and stress. All of these are modifiable. Alright. So this is the risk factor, and there's another one we call metabolic syndrome. Okay. This is the features of the metabolic syndrome. This is a risk factor. Anyone who have metabolic syndrome, any combinations of these, abdominal obesity, men more than 40 inches, women more than 35 inches, triglycerides more than 150 milligram per deciliter, HDL, men less than 40 milligram, and women less than 50, blood pressure of more than 130 over 85 millimeter mercury, and fasting glucose more than 100 milligram per deciliter. So this is for diagnosis of metabolic syndrome. So people who have this have a higher risk factors, including all the previous one, this one, okay. And if you have this metabolic syndrome, it will be of a higher risk to get ischemic heart disease. Because ischemic heart disease causative, the cause majority are atherosclerosis, you can see that the risk factors are of a shared. Sama lah, coronary atherosclerosis risk factor somehow is the same as ischemic heart disease risk factor. Okay, because coronary atherosclerosis is the major cause of ischemic heart disease. Okay, so clinically, imagine the coronary artery, a pattern one will have a very nice flow of blood, but others, atherosclerosis, there will be blockage. So let's say if the obstruction is fixed less than 70% of this lumen, okay, patient usually asymptomatic, no symptoms. And if critical stenosis more than 70% of blockage, usually it will have symptoms with increased demand. So jalan biasa-biasa, okay, naik tangga 3 tingkat dah rasa mengah and sometimes angina. Okay, so that is symptom when increase in demand. Okay, when they have fever, sometimes because of increase in demand, okay, they can have symptoms. And in fixed stenosis more than 90%, okay, they will have symptom at rest. Okay, duduk dengar lecture macam ni pun can have
sakit dada,
chest pain. sometimes student dia chest pain sebab dia takut nak kena tanya soalan. Okay. So that one may not be due to this. Alright, so acute coronary syndrome. Types of acute coronary syndrome, you will have this unstable angina, STEMI and non-STEMI. So what is actually ACS ni, acute coronary syndrome? It is any group of symptoms compatible with sudden interruptions of the blood flow of the heart. Okay, start with okay, then sudden interruptions, which include unstable angina, STEMI. What is STEMI? This is ST elevations, myocardial infarctions. And non-STEMI ialah ST elevation, myocardial infarction. ST elevations refer to ECG. Dah belajar kan ECG? ECG. So associated with elevated demands such as exertion, emotional stress. Dia boleh lah kalau takut. Dekat ni boleh dapat. Emotional stress and physiologic stress, rupture of atherosclerotic plaque. For example, there's atherosclerosis and suddenly rupture and develop thrombosis, or partial or complete thrombosis of the infarct-related artery. Okay, we will see next. Okay, so the symptoms will be palpitations. What is palpitations? Your patients will describe as what? Rasa? Berdebar-debar. Rasa macam boleh rasa dia punya kegupan jantung tu. Pain, okay, described as pressure, squeezing or burning sensation across the precordium, may radiate to the neck, shoulder, jaw, back, upper abdomen or either arm. Okay, exertional dyspnea that resolve with pain or rest. Diaphoresis from sympathetic discharge. This is where you sweat profusely. Okay. Nausea from vagal stimulations and decreased exercise tolerance. Okay, dulu boleh lari full marathon, lepas tu half marathon pun tak larat, lepas tu dah 1-2 kilometer pun dah tak boleh lari. So, that's it lah. But marathoner usually don't have this usually, but some cases where this kind of people have developed MI while running and whatnot. Okay. So what would be the physical finding when you examine symptoms is the one that patient complain to you. Okay, physical findings, hypotension, so indicates ventricular dysfunction. If it's hypertension, may precipitate angina or reflect elevated catecholamine levels due to anxiety or exogenous symptomatic stimulations. You can sometimes see jugular venous distension. When you examine, hold the hand, there will be cold, clammy skin, and diaphoresis in patient with cardiogenic shock. You can hear this is third and fourth heart sound, okay, or a systolic murmur related to dynamic obstructions of the left ventricular outflow tract. Sometimes you can see pulmonary crackles, okay, suggestive of left ventricular dysfunction or mitral regurgitations. So this is physical findings. You will see in the clinical posting later. Okay. So angina pectoris, or usually we just mention angina. Okay, this is intermittent chest pain, transient, reversible myocardial ischemia. Okay, so the ischemia somehow will release adenosine, bradykinin, and other molecules that will stimulate the autonomic afferents, cause the pain. It is reversible either by rest or sometimes by nitroglycerin. Saya ubat, tengok cerita zaman sekarang dia tak lagi cerita kalau sakit jantung dia letak ubat bawah lidah tu. Tengok tak? Drama Yustan selalu ada dulu lah. Okay. So it is due to ischemia, not yet infarction. Actually, not yet infarction. Okay, because it's reversible. Okay. So you will see variants of angina. One of it is typical, or we call it stable angina. As I say, you can use typical angina or you can use stable angina. This is episodic chest pain on exertion or some other increase in demand. Okay, for example, in tachycardia, okay, increase in demand, you berkebun ke, you go running, and sometimes you have fever, or maybe you see your crush, any increase in demand, palpitation not due to ischemia, but you get tachycardia because you berdebar sometimes. Okay, crushing or squeezing substernal sensation radiate down to the left arm or to the left jaw. Okay. Sometimes to the back, the scapula to the left side. Lepas ni kalau sakit tangan tu you get FI. So macam tu. Okay. Relief by rest, okay, when you reduce demand, or by drugs such as nitroglycerin or vasodilator that increase coronary perfusion. So this is what that ubat bawah lidah tu buat lah. Okay, somehow it cause vasodilatations and increase coronary perfusions. Okay, supply more oxygen. So if you tadi tachycardia yang berdebar-debar, okay, so you relax, cool down, so the heart rate will reduce in demand, so the pain will somehow relief. So that is typical and stable angina. Remember, this is due to acute ischemia, not yet to the MI. MI lagi ya. Okay. Another one is prismatal or variant angina. Okay. Occur at rest. This is caused by coronary artery spasm. It can actually occur on exertions, but it can occur at rest also. Macam tadi yang stable angina, it only occur when there is increase in demand. But here, the original coronary artery is actually normal. There's no atherosclerosis, no blockage, but somehow coronary artery spasm occur. Okay, some person with a certain genetic markup somehow have this tendency, okay, or certain disease can cause artery spasm. Okay, completely normal vessel can be affected. Respond promptly to vasodilators such as nitroglycerin and also calcium channel blockers. Because it spasms, it can easily go back to normal. All right. In forensic pathology, usually when you have sudden death, and if the cause is prismatal or variant angina, then later, because it is not released, the spasm, it can somehow cause myocardial infarctions, or it can somehow cause fatal arrhythmia and can cause sudden death. When you examine, you won't see anything. The heart is like completely normal. Tak ada apa-apa, because masa dia sakit tu dia spasm, when they die the spasm somehow release, so it comes to you with normal blood vessels. There's no atherosclerosis, okay, but they died of sudden cardiac death because of this. Okay. Next one, tadi stable, variant and unstable or crescendo. Dia ni macam crescendo sebelah dia music. Descendo, okay. Dia macam turun naik lah. Unstable. Increasingly frequent pain precipitated by progressively less exertion or even occurring at rest. So it usually start with stable angina. As time goes and they get worse, they can have unstable angina. Okay. Dulu boleh jalan turun daripada tingkat 6 sampai di tingkat 4 kan. Boleh turun tangga. So lama-lama turun tingkat 5 pun dah tak boleh dah. Macam tak larat. Semakin teruk. Okay. Usually is associated with plaque disruptions and superimposed thrombosis, distal embolizations of the thrombus and or vasospasms. Okay, there are the existing atherosclerosis, and rupture of plaque can trigger formation of thrombosis. Okay, sometimes the thrombosis is not that bad to totally block. Okay, it just cause unstable angina instead of MI, but somehow unstable angina can be part of acute coronary syndrome. Dia dah macam pending nak MI tau. Pending myocardial infarction already. Okay, if the thrombus somehow grow big and bigger and totally occlude, it can cause myocardial infarction. Alright. So the next one is MI lah, AMI. So where cardiomyocyte death, necrosis of heart muscle resulting from ischemia. Just now in angina, the ischemia somehow transient. Sekejap je. Okay, they just reversible injury of the cells. Okay, there's no cell death yet. But if the blockage is persistent, they can have myocardial death and necrosis. This is where we call it myocardial infarctions. 10% of MI before age of 40 and 45% before age of 65. So this is basically, generally speaking, is above 40s disease. Men are significantly greater risk than women. Women tend to be remarkably protected against MI during their reproductive years because of the, thanks to the estrogens. So when you go menopause, usually we will do a risk assessment and suggest to have a hormone replacement therapy so that you can have longer protections by the oxygens, right? So clinical features of myocardial infarctions, it's the same pain, but it's more severe compared to angina. It's like crushing, substernal chest pain or pressure that can radiate to the neck, to the jaw, okay, epigastrium or left arm. Sometimes they cannot. People who have GERD, GERD, okay, that's gastroesophageal reflux. And sometimes when they have GERD, they think it's MI. Okay, and sometimes when they already have GERD, when they have MI, they cannot distinguish between is it GERD or is it MI, because somehow the pain is around the same area. Okay, I had a case, a very young man who had MI. Okay, dia bulan puasa, dia pergi klinik swasta lah sebab dia sakit. Okay, because he is young, 20 plus. If I'm not mistaken, he was 28. And it was a fasting month. And of course, usually it's fasting month, people will get ulcer, gastric and whatnot. So the doctor did not suspect of any myocardial infarction because he is young and quite a bukan besar obese people, just normal lah, normal. Okay, I maybe a bit on the large build, tapi bukan gemuk tau. Okay. The doctor did not suspect of any MI, so think that it is just GERD. Okay, because of fasting and whatnot. So ask him to buka puasa and bagi dia, of course, the ubat gastrik tu lah yang berangin-angin tu kan. Okay, he on the way from the clinic back home, park his car emergency dekat lane tepi. If you know Akleh, you lalu Akleh tak? Dekat atas Akleh tu, park the car kat tepi and died inside the car. And we do a postmortem examination is coronary artery thrombosis, SAMI. So you know that the symptoms could be similar. So even though you have a young man, okay, especially men, a young man with that kind of symptoms, do one ECG. When you practice later, it's safe for you to do one ECG lah. Just take one ECG. Okay, it could be MI lah in a young patient. Okay, typically lasts several minutes to hours and it's not relieved by nitroglycerin or rest. Minority of patients have atypical signs and symptoms and may even be entirely asymptomatic, especially in patients with diabetes. Okay, because diabetes, they have some sort of neuropathy, so they don't really feel the pain. Ataupun sepatutnya kalau orang lain pain 10/10, dia mungkin rasa 5/10 je. Okay, biasa-biasa je. Okay. Silent infarct is common in patients with underlying diabetes mellitus. Okay. And in elderly persons. Okay, sometimes they atypical signs ni, it's not really like this. Sometimes we had a case when he presented like apa, epilepsy, macam sawan. Okay, so they thought it's something with the brain, but it's actually MI. That's atypical sign. Clinical features when you examine, if you got to examine the patient, they can have rapid and weak pulse, okay, diaphragm or nauseous, dyspnea, itu impact myocardial contractility and dysfunctions. Okay, massive MI, if it's involved more than 40% of left ventricle, they can have cardiogenic shocks. Okay, and ECG, they can have Q wave, ST segment change, and T wave inversions. Arrhythmia caused by electrical abnormalities in ischemic myocardial and conduction system are common. Okay, if they come to you fast and you sempat do ECG, you will see arrhythmia. And sometimes this arrhythmia, because most of the time, this arrhythmia is actually the mechanism that lead to the death, not really the complication of myocardial ischemia. Okay, this arrhythmia. Okay, the arrhythmia, because it will kill very fast. Very fast. MI, sekejap je, arrhythmia, die. Okay, so tak sempat kita nak tengok pathological changes within the heart. Okay, you will see later. Okay, majority due to acute coronary artery thrombosis. So you can see this picture. This is a patent coronary artery. So this one you dah dapat slit-like lumen. So this is the coronary atherosclerosis thrombosis. Okay, other causes: vasospasm, embolization from neurothrombi. Neurothrombi in case of what? You can have neurothrombi. No, effective endocarditis. You can have neurothrombi kan. So that neurothrombi dia boleh shoot out. Okay, keluar. Because you know if it's go out through aorta. So dekat aorta ada apa? Just above the semilunar valve, the ostium. You know the ostium? The ostium that leads to the coronary artery. Sometimes that embolus, emboli masuk dalam the ostium tu, go to coronary artery and cause death. Okay, tak ada coronary atherosclerosis but have thrombosis going. Could be due to some kind of neurothrombus. Right. Prolonged period of increased demand, like necrosis of the myocardium most distal to the epicardial vessels, ischemia without atherosclerosis or thromboembolic disease. Okay, sometimes it's due to this disease lah, vasculitis, any amyloid deposition, stasis due to sickle cell disease. Okay, within the vessels, that's not associated with atherosclerosis or thrombosis, other disease, but this is not that common. It can happen, but it's not that common. Most common, yeah. You can see this is the normal one. Then you have coronary obstructions. Okay, the typical angina, and you have plug destructions, thrombus. This one can lead to myocardial infarctions. Okay, chronic ischemic heart disease, severe fixed coronary. This one, okay, can have angina also. Okay, can have unstable angina. This go here. Okay, intraplug hemorrhage or mechanical force, exposing subendothelial collagen and necrotic plaque content to the blood. So this is how coronary artery occlusion occur. You have learned in coronary atherosclerosis lecture, right? Okay, so platelets will adhere, aggregates, activated, okay, and activation of coagulation by exposure of tissue factor and other mechanism adds to the growing thrombus. Okay, so all of this go back to the formation of thrombosis lecture. So pattern of infarctions. So depends on the location, size, and morphological features of acute myocardial infarction. So depends actually on the size and distributions of the involved vessel. So the coronary artery, what is the three major branches? The depan, left, and the right. So left ialah left anterior, descending, then to the right, dia akan ada right coronary artery, and usually it will make up the mana dia supply. Okay, left kalau right coronary line. It supply mana? The right ventricle belakang, and it can branch into the marginal artery, and you have also left circumflex artery. Okay, so three major branches. The rate of development of the durations of the occlusions, metabolic demand of the myocardium, and extent of collateral supply. If you notice, it sounds familiar from the first two lectures. Okay, masa you belajar ada cell injury. Okay, size and distributions of the involved vessels. So which vessels? Is it the L18 or is it the right coronary artery or left circumflex artery? Which one? Okay, and location, is it proximal or is it distal? Okay, if it's distal, it might just affect the apex. If it's more proximal, it can affect larger area. Okay, so rate of development, okay, depends on the occlusions within, how fast that the thrombosis develop. If the coronary artery is quite bad, already more than 85%, 90% occluded, and sudden plaque disruptions, so obviously you can imagine cepat lah kan dia become blocked, compared to the one that have maybe dalam 30% of occlusions. Then when the disruptions, it will take some time to totally block. Okay, metabolic demand of myocardium. Again, if the myocardium is hypertensive heart, dah lah block, lepas tu originally memang demand is high because of hypertrophy, so it's faster getting the myocardial infarctions. Extent of collateral supply. Okay, so this tepi-tepi ni is all collateral supply, so depends on how long the occlusions has been there, your body might develop collaterals. So if it's blocked here, but you get lots of collateral starting up there, okay, the heart might survive, or the area that affected could be smaller compared to if there's no collateral, right? So patient macam mana nak dapat collaterals ni? Dia slow, so it's chronic occlusions lama, a long time. Okay. If proximal, left anterior descending artery, this is 40% to 50% of all MIs. Favorite spot dia lah, okay, of the proximal third of the LAD mostly. So infarctions of the anterior wall of the left ventricle, because it supplies this area ni kat sini ya. This is the LAD. Okay, so sini lah, like this is anterior, this is the LAD. If it's proximal to this area, so this is the area where it supply, so it can cause myocardial infarctions on the anterior and the anterior half of the septum, this area. Okay, sometimes here lah, depends. If proximal, left circumflex artery, about 15% to 20% of MI. Okay, necrosis of the lateral left ventricles is here because it will go here, here and also here, circumflex di belakang. Proximal right coronary artery is the second most favorite locations. Okay, so it will cover the right ventricles and posterior third of the septums. Posterior third of the septums. Okay, posterior descending artery. Okay, this come from right coronary artery. Why 90% arise from right coronary artery in the case of right dominant? If it's left dominant, usually it's so it come from the left lah. But majority of human being are right dominant. So 90% of posterior descending artery come from right coronary artery. So may also affect secondary branches, the diagonal branches, and the marginal branches. So this is the area that they prone to have this atherosclerosis and later lead to blockage. So here you can have obstructed artery. So usually it will affect the distal part first. Okay, the distal part. So you have subendocardial infarction. If it's bad and over time, so like this is in 2 hours and over time, it can cause transmural. So if it's from subendocardial nanti atas ni, we call it transmural infarctions. Okay. So blockage here, it will cause distal ischemia and infection. So this is area at risk lah. Kalau dia ada collateral sambung sini, from here collateral sambung sini might be reduced injury. Could be injured also, but maybe reduced injury. So transmural infarction, so it involves the whole part lah, the whole thickness of the myocardium. Okay, so it will cause this STEMI. Tadi kita dengar STEMI, ST elevation. So they have this ST elevation. STEMI, STEMI is the transmural infarction. Full thickness of the ventricles and caused by epicardial vessel occlusions. Yield ST segment elevation on the ECG. Can have a negative Q wave with loss of R wave amplitude. It's also called ST elevation MI or STEMI. So at this point in year 3, you have to know that ST elevations, this STEMI is associated with transmural infarctions due to the occlusions, severe occlusions over here. Okay, when you go to clinical year next year in medical, ni semua you kena hafal lah ni, mana Q wave, mana ST elevated, you must be able to read the ECG of this STEMI. Okay, so subendocardial infarction limited to the inner third of the myocardium. So not all subendocardial infarction will progress to transmural. So again, it depends on the extent of the blockage and the blood supply. Okay, do not exhibit XT segment elevation or Q wave on ECG. So this is non-STEMI tadi, non-STEMI, non-ST elevation MI. So tak ada ST elevation. Okay, severe coronary artery disease, transient decrease in oxygen delivery or increase in oxygen demand. This can occur when an occlusive thrombus lies before a full thickness infarction can develop. Okay, let's say there are thrombus tapi very fast dia dah lies, or some kind of intervention has been done. Okay. So microscopic infarct, this is small vessel occlusions, may not show any diagnostic ECG changes. Sometimes it's due to vasculitis, the disease of the vessels of the heart, embolization of valve vegetation or mural thrombi, but this is, you can imagine, very small emboli. They just go to the it's not the main coronary artery, but the vessels that penetrates the myocardium. Okay, it can due to vasospasm due to elevated catecholamines, in endogenous causes due to fuel chromosatoma or extreme stress. Sebab tu extreme stress can cause MI, okay, because of increased catecholamine. It is not a full-blown large myocardial infarction. It's just microscopic infarct. But microscopic infarct is fatal if it's too many. Okay, and exogenous, for example, in cocaine addictions, patient with cocaine addiction, they can have microscopic infarct. Small. So infarctions, you have to know, under pathology, you have to know the microscopic features of myocardial infarction. So you can see here transmural infarct, and this is non-transmural subendocardial infarctions. Again, depends on the which vessels occluded. So this is posterior, this is laterals, okay, left circumflex branches, this is anterior. Is it? Okay, right, anterior. Anterior. Okay, anterior is posterior. Okay, so this is small intramural vessel occlusions, the microinfarct part, dia kecil-kecil macam tu. Okay, but somehow if it's too many, it can cause complications. So pathological changes. This is generally you have to know this, that time frame. This is under light microscopy and electron microscopy, so this is more important. So 0 to 1.5 hours after myocardial infarction, usually you won't see anything. Okay, you very sudden death because of the arrhythmia that I told you. Okay, usually tak ada apa-apa. After half to 4 hours, gross feature also you won't see anything. Light microscopic usually none, but you can see variable waviness of fibers at the border. Usually at this time yang dapat tengok variable waviness is a cardiac pathology. So I tengok pun I might not be able to recognize it. Okay, because you have to really look at lots of vessels, myocardium under microscopy to be able to recognize this. So 4 to 12 hours, you can see gross feature, dark mottling, occasional, it become a bit darker than the surrounding tissue, beginning of coagulation, necrosis, edema and hemorrhage. 12 to 24 hours, you can see dark mottling, and you can already see coagulation necrosis, pignosis of nuclei, hypereosinophilic appearance of myocytes, some marginal contraction band necrosis. Okay, 1 to 3 days, you can see mottling with yellow tan infarct center. Okay, microscopically, you can see coagulation necrosis with loss of nuclei. 3 to 7 days, you can have this hyperemic border, central yellow tan softening. So begin this integration of dead myofibers. You can see neutrophils here, more neutrophils after dalam 1 week macam tu. After a week, okay, maximal yellow tan and soft with depressed red margin. So well developed phagocytosis of dead cells. Okay, about 2 weeks, you can have red-gray depressed infarct. You can see granulation tissue. You still remember granulation tissue?
Yeah.
What is it? Ada apa kat granulation tissue? Lagi? So ingat, the granulation tissue tu bukan dekat skin je tau, dia ada dekat tempat mana-mana, ada healing lah. So basically about this time, the necrotic myocytes is already in healing progress. It healed by scar formations. Okay, so about 2 to 8 weeks, you can see that grey-white scar progressive from border and increased collagen deposition. So dekat 2 minggu ni, you can see a lot of granulation tissues, and of course all the granulation tissues lah, apa benda kat dalam tu. Okay, and more than 2 months, you can see scarring, complete dense collagenous scar. Okay, this is important because you want to know that this person, how long is the MI had occurred before the death lah. Sebab you nampak, you tengok, kalau tak mati, you won't see microscopic finding. Okay, because kita tak buat apa, sampling tau, tak ada. Okay, in case of MI, kita buat sampling. So this is that. So we will continue this topic next year and talk about this next year during forensic posting. Why is it important? Why is it significant? Okay, so bersabar setahun lagi. Right. So from the description just now, yang ni dah berapa lama?
2 weeks.
Nah,
I don't know what I think.
so how do you describe this? Warna apa?
Yellow. Pretty
Yellow.
light.
Like more like white tan, white lah.
White.
Okay, yellow is yellow. This is more yellow, and this is more white. So this is basically the scarring, the fibrosis, subendocardial fibrosis. Actually, it's involved here is full thickness transmural. Okay. Oh ya, lupa nak sebut. Okay, so around this area, 3 to 7 days ni, you can have central yellow tan softening, ada disintegration of dead myofibers. So around this time, 3 to 7 days, the myocardium, the necrotic myocardium, have tendency to rupture because it's soft. Kalau dia transmural, kan, daripada dalam sampai luar and it becomes softening, can you imagine heart is pumping so hard, it can rupture. So cause pericardium. Okay, so this picture is actually the fibrosis. Okay, you can see this area.
Hemorrhagic.
What color?
Yellow.
Yellow. So this is the hyperemic border, and this is the yellow center. You can see this is yellow and some dark mottling over here. So this is the area of necrosis just now after a few days. Okay, you can see this. Sometimes we call it thyroid. So dia macam berbelang-belang. Ini hyperemic, this is yellow. So this picture yang dah fix yang tadi this picture is soft, tak fix lagi, ni dah fix dalam formalin. Actually this area is where we put this TTC, trophenyl tetrazolium chloride. So when we put here the area yang tak ada infarctions tu, they will void of color. Okay. So this one area dah sometimes, this one area of the new infarct. So this one long because whitish. So this is a chronic ischemic heart disease. Okay, the previous infarct, but a recent infarct and very new infarct. So under microscopic 12 to 24 hours, you can see contraction band necrosis. Nampak tak ni?
Oh, nampak.
This area. Besarkan sikit ni. See? Okay. Can you see? Okay. Somehow, if you still remember your normal histology, myocardium dia akan ada apa? The striation, but this is not the normal striations. Okay, this is the contraction band. We call it contraction band necrosis. As you can see, tak ada. There's no nucleus. And what is this?
Lymphocyte.
What do you think?
Neutrophils.
The neutrophils. Start coming in. But ni dah necrosis. About 12 to 24 hours. So belum banyak lagi, but it start coming in because they want to clear the necrotic cells. Okay, remember? So this is HNE. This is PTAH, phosphotungstic acid hepatocyllin, special stain to visualize clearly. Okay, you can see it visualize clearly the contraction band. Okay. So this one, this is contraction band. Okay. So this area not that bad. So this area lah, important area. So this is after up to 3 days durations. You can see that there's no nucleus, okay, and lots of apa? Apa? Ni sebut ni apa ni? What cells?
Inflammatory.
Neutrophils. Yes, inflammatory cells. Neutrophils. Okay, and this is 7 to 10 days. As you can see that this one normal lah kan. Ada lagi liver cell, but this one dah you can't really see the myocytes. It's gone. Okay, and you can see very plump cells of macrophages taking up all this part. Okay, about 7 to 10 days duration. And this is 1 to 2 weeks and more than 3 weeks. So what's the blue one? Apa yang blue tu? This is not H&E. This is a special state to visualize this bilirubin. Apa? Cepat sikit tak dengar. What? Alah apa? Collagen. Okay. So you see 1 to 2 days there's collagen, but it's kind of loose, sparse collagen. And after 3 weeks, we can see that more dense collagens. Okay, that bluish thing. Okay, nampak ni macam strand lah, still collagen strand. Dia tak as dense as this one. Alright. So obviously this is the granulation tissue lah. You can see the neovascularization, there's collagen. Under this thing tak nampak sangat the fibroblast, but there is lah. Kita baca tu. So that's morphology, gross and also microscopic. That's a thing what we call perfusions injury. This is therapeutic goal to salvage the maximum amount of ischemic myocardium. So there is thrombosis and they do thrombolysis. So basically dah sempat hantar patient pergi hospital, they do thrombolysis either by interventions ataupun by drugs. Okay, so restorations of blood flow into the ischemic tissue can incite greater local damage that might otherwise have occurred. So this is the perfusions injury. Okay, hemorrhagic as consequence of vascular injury and leakiness. Microscopically, you can see contraction band necrosis. Reperfusion can salvage irreversibly injured cells. It also alters the morphology of irreversible injured cells. So the aim is to save the cells, the myocardium, but somehow it cause more injury. Okay, so heart ischemia reperfusion. So you can see that what happened here is the autophagy and also the oxidative stress of the ROS that cause more cell death in the case of reperfusions injury, right? So this is an example of reperfusion injury, very recent infarct, but dah nampak. Kalau tadi kita tulis sebab after a while kan baru dia nampak dark mottling ni, but this is due to reperfusions. Mula-mula ischemia, sepatutnya white infarct, but and they suddenly remove the thrombus and the blood flow as usual, and it causes hemorrhagic infarctions over here. Under histology, you can see contraction band, and you can see blood RBCs. You can see RBCs interstitial. Okay, because of leaking of blood in this case. Okay, dia dah ischemia, but suddenly there's a blood flow, so the blood flow goes seep into the interstitial. So you can see RBCs in between the myocytes and the contraction band. Okay. So chronic ischemic heart disease with congestive heart failure. So this is progressive cardiac decomposition after acute MI. So can you imagine this area dah infarcted and they cannot contract properly. So they can have a heart failure later lah. Secondary to accumulated small ischemic insult eventually precipitate mechanical pump failure. Okay, kalau microscopic infarct also can cause pump failure. Okay, can have congestive heart failure. So it depends on which side of infarct. Okay, and sudden cardiac death can occur as a consequence of tissue damage from MI. Most commonly result from lethal arrhythmia. I mentioned to you before, triggered by electrical irritability of the myocardium. Kan, sepatutnya normal. You remember the conductivity, the SA note, okay, the AV note, okay, and the bundle of his and whatnot. Okay, so imagine they have to go through, but certain area dah mati, necrotic, so there will be haywire. Okay, the conduction system tu be haywire and cause lethal arrhythmia, thus cause sudden cardiac death. Okay, other complications include contractile dysfunction, affect left ventricle pump function in proportion to the volume damage. Okay, depends. If it's too bad, it can also cause left-sided heart failure if it's on the left side. Okay, can cause hypotension, pulmonary congestions, and pulmonary edema. You will learn more in the heart failure lecture. Okay, but you have to know how to, connect. And severe pump failure in cardiogenic shock. Of course, you have learned cardiogenic shock. There's no problem for you to understand why MI can cause cardiogenic shocks. Okay, what is this? Apa? The papillary muscles. Okay. If the infarction involve this side can cause, ni nampak dia dari yellow tan macam ni. This infarcted, necrosis area. Okay, necrosis area. It can rupture because after a while they become soft kan. It can rupture and cause the valve incompetence. Or if it's not ruptured, it become fibrosis. Dia akan jadi it can jadi, boleh jadi competence juga lah. Boleh jadi rigors also. Okay, kalau dia rupture, dia boleh jadi rigors. Okay, can be dysfunctional and can be polycontractile, post-infarct mitral rigors. Can have rigors. So sepatutnya papillary muscles ni like hold kan, hold and control the valve kan. So the next complication, right ventricular infarction. In the case isolated right ventricular infarction, which is not very common, but if it's happened, it can cause right thinning of the right ventricular. Okay, and it can cause myocardial damage and also rupture also. Okay. Injured in association with septal or left ventricular right-sided heart failure is common outcome lah if you see isolated right ventricular failure infarction. Right ventricular infarction can lead to right-sided heart failure. Okay, myocardial rupture as I mentioned just now. Okay, ni dah potong jangan pening kenapa dia duduk like this. So here is the where it's ruptured, because the area of infarction is around here that it can rupture. Left ventricle most common. Okay, rapid fatal heavy pericardium and cardiac tamponade. You know what is cardiac tamponade, right? Kan? Okay. So ventricular septal rupture creates VSD. Kan? Ventricles boleh rupture juga, ada VSD. Papillary muscle rupture lead to mitral regurg. Okay, this commonly 3 to 7 days after infarction. I have told you why. The risk factor of free wall rupture is older age, anterior or lateral wall infarction, female gender. Why female gender? Why? Sebab heart dia kecil sikit, and muscles of the heart pun comparatively thinner compared to male kan. Okay, lack of ventricular hypertrophy, first MI, as cardiac associated with prior MI tend to limit the risk of myocardial tearing. So kalau first MI terus transmural and female and tak ada, there's no underlying ventricular thickness, so it's more easy to get rupture, very fatal. Okay, sorry, arrhythmia. So this leads to myocardial irritability and conduction disturbance. So 90% of patients develop some form of rhythm disturbance after this following STEMI, higher in STEMI lah versus non-STEMI. So can have heart block, series of arrhythmia, ventricular fibrillation, greatest risk of first hour and declines thereafter. So the first hour is very critical for you to manage these MI patients. Sorry. So pericarditis, transmural MI can elicit fibrinohemorrhagic pericarditis. Okay, epicardial manifestation of underlying myocardial inflammation. So it somehow would involve them because it's transmural, it's go to the epicardium and can cause pericarditis. It somehow triggers some sorts of inflammations, and it can have any inflammation and necrosis can have later healing, so there can be fibrous around there. Okay, and chamber dilatations because of weakening or necrotic muscles. You can see this is thinning and dilatations. Okay, and because of this, it's prone to get mural thrombus. Okay, you understand why? Again, because of disturbance of the flow of that area. Okay, ventricular aneurysms, somehow this thinning can also cause dilatations, okay, and cause aneurysms and progressive late heart failure. So from left-sided heart failure, if they have left myocardial infarction, left ventricle MI, they can lead to left heart failure, and over time they can progressive to congestive heart failure. Okay, bilateral, left and right. Okay, you will understand when you go to lecture on heart failure later. So this is basically a mural thrombus, okay, around this area. So lab diagnosis, as you know that any disruptions of muscle, any dead muscles, they will release certain chemicals. Okay, so you can see release into circulation from necrotic heart muscles, myoglobin. This is the first serum marker to rise after MI, but lacks specificity because skeletal muscle, if it die, also can release myoglobin. So we don't really measure clinically. We don't really measure myoglobin. Okay, because it's not specific. We want specific. Okay, CK, creatine kinase, rise 4 to 8 hours after onset of MI, normalized by 48 to 72 hours, not specific for myocardial necrosis. Tapi kita ada MB daripada CK ni ada MB isoenzyme. This is more specific. Okay, this is more specific and more sensitive and specific than CK and CKMB is the specific troponins. So usually now clinically, usually what we do on bedsides, even in post-mortem room, we do this quick troponin, either troponin I or troponin T lah. This is troponin T and troponin I. So it rise quite early. Okay, rise quite early and stable, and it is more specific to myocardial. So if you go to clinical practice later, the troponins is the current practice lah. Yeah? But you have to know all of this. You have to know all of this. So I think that's all for this topic.